Ladies and gentlemen, welcome once again to the Think Clinical podcast. My name is Hamza. It's great to be here. It's always amazing to have these conversations, and today I'm particularly excited because there's been a lot of conversation around whether or not AI in healthcare is coming in to replace physicians or other work groups, or it can actually be that tool that we use to elevate decision making. Is it going to be a tool that we can use to elevate decision making, or is one that we probably should be looking at the fact that it has the potential to replace our workforce? I'm going to look into that today. We are going to use some really good data to support whether or not integration of AI into healthcare is becoming a replacement for the workforce we have, or is going to be a tool that enables healthcare professionals to be able to elevate their decision-making process. So once again, this is the Think Clinical podcast. My name is Hamza. It's always great to be here. Remember to subscribe, like, and share the video so that anytime we post anything, you are able to follow and get a notification as soon as this is up. So ladies and gentlemen, when we look at this, right, let's start by addressing the elephant in the room. And so when we look at a survey that was done in 2024 by the American Medical Association, they found that 67% of physicians initially feared using AI, which is an accurate representation of the number of people who did not feel comfortable, and probably still a significant number who do not feel comfortable today. But this was just back in 2024. So we need to understand that there is already a stigma out there about using AI, and about even just not healthcare but different working groups identifying that AI will probably replacing their job. But my job here is to look at AI in the context of healthcare and whether or not it's replacing the role of a doctor or any clinician, or it's elevating or helping them elevate their decision-making process. So that one of the things that we need to look at is this. In Mayo Clinic, they have an AI-powered ECG analysis. And this represents the perfect example of when we talk about elevating and not replacing the clinician in the hospital. Because regardless of what we do, and we'll look at this later in the podcast, you cannot replace certain qualities that a physician will demonstrate. And we'll talk about all these the podcast. Now, this system that is in Mayo Clinic that enhances their ECG analysis is able to pick up atrial fibrillations with 83% accuracy, even if patients are showing somewhat completely normal rhythms to the human eye. But the crucial point here is that it doesn't make the diagnosis for you. It actually flags cases for clinicians to go back and look and review and actually help them transform what could have been missed, or could have been a misdiagnosis, into more like a targeted clinical investigation, right? Now, when we look at one of their very well-renowned electrophysiologists, he explains it very well. He says, AI sees patterns we can't, and we make decisions it can't. So we as humans still have the ability to make the decisions that AI will never be able to, but AI has the capacity to efficiently see patterns that we possibly would miss from the human standpoint. Now, the system has from the Mayo Clinic has identified over 2,000 cases of atrial fibrillations that would have been missed. This is a lot of information, and so when you look at this from the point of how it helps the physician, it doesn't replace the physician. It actually goes a long way to be able to help the physician expand their decision-making rhythm. Let's go to Stanford. Now, when you look at the Stanford data, right, they have a dermatology department where they use AI, and AI has been able to show a 91% accuracy rate in dermatology diagnosis. This ties into the same diagnostic accuracy of a human-trained dermatologist, right? But this is not replacing the dermatologist. So when this research was started, it was started as a screening tool. But instead of it replacing dermatologists, it now helps dermatologists to actually triage their cases. So they're able to identify high-risk cases, and they're able to give them the attention that they need, compared to spending more time on cases that are mostly either benign or just routine screening cases. So this has actually, from the research from Stanford University, has actually showed that 40% dermatologists have been able to spend 40% more time on complex cases and giving the attention and try to help them fix those situations than spending their time looking at screening cases and looking at cases that should otherwise not deserve that level of attention. Now it goes all the way to Johns Hopkins, and they have an AI-powered pathology system which identifies cellular abnormalities in 99.5% accuracy. That's huge, and pathologists still interpret results. So it tells you that the AI system, which in this case for Johns Hopkins can process about 200 slides per hour, which is way beyond the human capacity, the pathology provides the clinical insight to this. So what that does is that, again, as I said, it's elevating the decision-making process for the dermatologist. So the third thing I would like to highlight here is the cognitive overload. Now, when you look at AI in the context of elevating decision making, it reduces a lot of cognitive overload. And I've seen a lot of departments, especially the emergency departments in hospitals, where we have hundreds and hundreds and hundreds of decisions that need to be made. Now this is a cognitive minefield. So physicians have to process hundreds of data points per patient while managing multiple cases simultaneously. And again, as a human, you only have the capacity for a certain level of mental processing. So at some point you start making mistakes. At some point you burn out. At some point you make suboptimal decisions. Now, if we look at AI and what it's been able to do, especially the single health systems, they have an AI-powered clinical decision support which examines over 30,000 data points per patient in real time. Now, it doesn't just tell physicians what to do. It provides evidence-based recommendations for these physicians to be able to accept. They have the option of modifying, and they have the option of overriding that decision. So again, it's not telling the physician what to do. It is giving the physician all the data that the physician needs to be able to make that decision. So you can either accept, you can either modify, or you can override the decision that it makes. It's still completely up to you. So when we talk about the former CEO of Gissinger, he reported that diagnostic accuracy improved by 17%, and while physician confidence also increased by about 28%. So what key insight are we looking at here? We are saying that AI excels in data synthesis and pattern recognition. We cannot compete with AI when it comes to those two qualities. These are tasks that overwhelm the human mind just like that. They do, because they actually put us in a situation where we get burnt out and we are unable to make such decisions way faster and easier than we are supposed to be making them. Now, when we look at this from Cleveland Clinic, their AI system continuously monitors patient data. It identifies sepsis risks 6 hours before the traditional methods. Now just imagine that while patients are in the hospital, you have a system that is continuously looking at their data patterns and evaluating it, and if there's a risk of sepsis, it picks it up 6. Now if you've been in a clinical setting, every hour you're able to diagnose sepsis before the time you traditionally have to get it, actually to a very favorable outcome. So these early warning signs have actually reduced sepsis mortality by 18% and has reduced hospital stays by 1.5 days. Now if you look at this from the financial standpoint, the hospital is now turning over more beds because they are able to pick up such issues and intervene. They are able to reduce mortality by 18%, so patient outcomes are excellent. And at this point, AI is only providing the signal for the doctor to intervene. Again, this is a typical example of situations where AI, instead of replacing the human because it cannot, is actually expanding the decision-making process of the human. So as I said, we are going to be looking at the most successful implementations, and what this is what I call the human AI partnership framework. Now we need to look at the 4 key functions of AI that way supersedes what humans can do, and let's look at the human the irreplaceable roles that humans would have or clinicians will have that AI will never be able to or will not be able to do at this point. Now, when we look at the 4 AI handles, 4 functions that AI is able to really assist and supersede whatever humans would be able to do, we are talking about continuous monitoring. We don't have the energy, the bandwidth, and we're just not set up to do any form of continuous monitoring of any situation. So if we look at the continuous sepsis monitoring tool that Cleveland Hospital has, no human has the capacity to go through that amount of data all the time and, first of all, not make errors or make suboptimal decisions. None. Now, pattern recognition is something that humans, we have the ability to do, but AI has enhanced our ability to actually read patterns. Data synthesis, you can dump millions and millions of data points into AI system and you make sense out of it within a few minutes. Humans don't have that capacity yet. It will take way more time for us to be able to synthesize that level, that amount or that volume of data. Now, when we look at risk stratification, same thing. AI is really good at these 4. So AI is good at continuous monitoring because it doesn't get tired. It's very good with pattern recognition, with data synthesis, and with risk stratification. Now, when we look at the human side, clinical reasoning is something AI would never be able to make. We have to take the information, synthesize, and be able to make that decision. Patient communication is something AI hasn't been able to come up with yet because it's just not built yet. It hasn't gone to that point where it's able to have that level of conversation or communication with patients. Ethical judgment, again, is something AI doesn't have the ability to do. And treatment adaptation, because we have the ability to look at what is being implemented and whether or not it's working. And if it's not, we change it. So these are some of the things. But let's examine through the lens of we look at this through the lens of IBM Watson for oncology, right? It initially struggled because they tried to replace oncology decision making. That was the main struggle for that system. And they had to go back and refocus on information synthesis instead of trying to replace oncologists. Now, the current system reviews thousands of research papers and just patient records, and it presents treatment options. Now, the oncologist still makes that treatment decision, and they are informed by a very comprehensive data analysis, which would take weeks to perform manually. So these are some of the examples, and I've given you countless examples of situations where we actually should be looking at AI as a tool to expand our decision-making capacity, instead of looking at this as competition and a tool that will replace our jobs sometime in the future. Now, when we look at the leadership imperative, the question isn't whether to implement AI, but how to implement it as a tool for human elevation. So when you are in healthcare leadership and you are looking at AI tools, so you're looking at it, building AI systems, you are looking at this from how you are going to implement as a tool of human elevation. How do you implement this such that it expands the decision-making process of your doctors, not replace their decision-making process? Now, let's look at this in different ways. The first way to look at this is make sure you preserve the human agency. Now, AI should expand options, not constrain them. So at Kaiser, for instance, the AI-powered medication management system suggests optimal dosing, but doctors or physicians or pharmacists always have the ability to override that. Now, when they track those override rates, they are not tracked as failures, they are tracked as learning opportunities. Now, the second thing you need to do as a leader, if you are trying to implement AI or AI systems in your hospital, and making sure that these are becoming decision-making tools instead of replacing the decision that the physician would have made, you need to maintain transparency, because when you implement black box AI systems that can't explain their recommendations, they create liabilities. So every AI system should have a guiding framework that can be explainable with all the output is giving you clinically. So physicians need to understand why AI makes, they need to. So you need to be transparent. The third one is to focus on cognitive partnership. So if you look at the most successful AI implementations, they reduce cognitive load and preserve clinical autonomy. So if an emergency physician has to look through so many data points in a day, through so many patients, and run through all these people, your ability to implement a system that reduces that cognitive load whilst preserving their clinical autonomy and allowing them to still be able to make those decisions is what actually makes successful. So Epic, for instance, they have their AI-powered documentation tool that is an example of such an approach, because it reduces chatting time by 44% whilst maintaining the physician control over initiatives. So these are the ways you think about them. So in conclusion, the evidence at this point, and I would say, is very clear. AI's greatest potential lies not in replacing humans, and I don't think people who are building AI systems are building them to replace humans, but in amplifying it, especially in our healthcare space. The most successful AI implementations, they create this kind of a symbiotic relationship where AI handles all the data intensive tasks and humans focus on the complex reasoning, empathy, and ethical judgment. So these are things that, regardless of how advanced we are, and I know we are going very far with AI, it will take a while for that to be taken away or replaced. Now remember, AI can process information faster than humans, and that is a fact. And it can care, but it can't care for patients. It cannot have that touch that a doctor or a human will have with the patient. It can definitely identify patterns that we miss, but it can't comfort a frightened family. So that's another thing that you should know, that this can never be done. We can use it to synthesize research, but it can't make any ethical judgment, especially about end-of-life care. These are things that we need to identify, that clinicians, and for that matter, doctors or healthcare professionals cannot be replaced, but we can use, and we should be thinking about using AI to expand the decision-making process. With that, thank you once again for joining us for this episode. This has been another exciting episode of the Think Clinical Podcast. Remember to subscribe, like, and share. We will be continuing this series looking at all these tools and how these can augment the system or whatever you have in the hospital in our subsequent episodes. So stay tuned, subscribe, like, and share so that you get an alert when this comes up. Have a beautiful day.